evening. I'm Bill Nygut, the host of GPB Radio's Political Rewind and Two-Way Street. We're here tonight to talk about the opioid crisis that's sweeping the country. There's been a 117% increase in opioid overdoses in recent years, and unlike other drug epidemics in the past, this one is largely driven by prescription drug abuse. Opioid abuse does not discriminate. It affects the old and young. It affects all races and every community. We've assembled a panel of experts to get the latest on the crisis here in Georgia from a law enforcement perspective. So let's meet the panel. We have the Attorney General for the state of Georgia, Chris Carr, the Commissioner of the Department of Public Health, Dr. Patrick O'Neill, the Director of the Georgia Drug and Narcotics Agency, Dr. Dennis Trofton, Special Agent Martin Highsmith with the Federal Bureau of Investigation, and Special Agent Patrick Gray with the Drug Enforcement Administration. So let's take a couple of minutes at the top and hear each of them with their perspective on just what the scope of this problem really is. And we'll start with the Attorney General. Chris?
Bill, it doesn't matter where we go in the state of Georgia. This is an issue that we hear about. Unfortunately, we know everybody's been impacted by. It's an issue that knows no geographic, demographic, or economic boundaries. As you mentioned in the open, it's impacting newborn babies. It's impacting children, youth that are involved in athletics, older adults that are getting a knee replacement or a back surgery. So it's an issue that is impacting us no matter where we are, and it's an all-in issue. It's an issue that you got to have everybody at the table, because you got to have doctors, and you got to have pharmacists, you got to have law enforcement, you got to have nonprofits. So it is an issue that we see no matter where we go, statewide issue that's got to have a statewide solution.
All right, thank you. Dr. O'Neill, you see this from a very important perspective, dealing with the public health of the state of Georgia.
I do, Bill, and actually I see two areas that really are important to me. I travel the state on a regular basis, and I have yet to find a single family that has not been impacted either directly or indirectly with the crisis. That tells me the scope is monumental. And secondly, I've been actively engaged now for over 30 years in Georgia in the formation of a trauma system. I was appalled in 2014 when all of a sudden in that year the deaths from overdoses exceeded the deaths from car crashes. The scope is immense. I see it in those two ways.
Yeah. That's an astonishing figure, to hear that opioids are causing more deaths than car crashes. Dennis Trofton, what's your perspective on how widespread this problem is from your agency's point of view?
Well, and as a practicing pharmacist as well, I've been a pharmacist for 32 years, and so I've seen this grow tremendously from one side of the counter and then flipping to my side of the counter now, if you would, as an enforcement officer for the state of Georgia. We enforce for the Board of Pharmacy as our primary objective, and so there's a balance between retail pharmacies and getting the drugs through good physicians to the people that truly need them, and determining which ones are going out the back door or going to the places they don't need to go because people are trying to make a dollar. So I think for our agency and our perspective, it's a balance as well as going after the bad guys.
Okay. Martin Highsmith, FBI, how do you look into this? You're out there on the streets dealing with opioids regularly.
Well, the FBI, we do recognize that there's an increase of opium-related crimes. With that being said, we have several programs within the FBI to combat or help try to reduce this. Now, I'm part of what we call a strike force, and it's a regular drug squad that, and what you guys would commonly see on, on TV or something, that we investigate the regular drug crimes.
I love those shows.
Yeah, they're great. I love them too. That's where I get all the tips from.
Yeah.
So, what makes our squad, the strike forces, really well is we are commingled with DEA. So we have two agencies that basically mind meld together to help combat these drugs. Now, we also have other programs like healthcare fraud. Healthcare fraud, they're looking at the investigative aspect of where doctors are false billing for examinations that they're not doing, writing prescriptions. They're helping. They're working with local and state agencies to look at the falsing, like I said, the fraudulent insurance programs, and then also working with the pharmacies to see that they're actually filling these fake prescriptions. We also have the gang squad. Everybody knows that gangs, one of their revenues is drugs. So the gang squad's out there helping with this crisis by not only investigating violent gang activity, but also the drug activity. And then we have the cyber squad. They also investigate things that they're using the internet to help facilitate the sales of these illegal narcotics. Now, the great thing about the FBI is I've given you about 4 programs, but within those 4 programs, we can cross programs. So a strike force can be investigating, say, the street level part of investigation, but then we can commingle with our cyber guys to help us investigate the internet portion of that. Same thing with healthcare and the internet as well.
Okay, thank you for that. Patrick Gray, I always think of DEA, and I may have it wrong, so I need you to correct me. When I think of you dealing with drug issues, I think of you being the guys who break down the door and go in and grab the bad guys. But I suspect your role is much broader than that. So what is your perspective on this?
Well, our role is similar to that. The group that I work in here in the Atlanta office mainly conducts small-time investigations in the Atlanta area that then grow into larger organizations. From DEA's perspective, this problem is a global problem. The drugs start in areas in China and laboratories over there. They make their way across the ocean down into Central America, Mexico areas. Precursor chemicals are more easily obtained in these areas, and these drugs are smuggled across the border into our cities and on our streets. So the investigations here, they start small sometimes and slowly build up, but from our perspective, it's a global problem that we have to fight both internationally and here at home.
So it's interesting, we hear 2 different issues about drugs. We hear the prescription side of it, legally prescribed drugs, and then we hear about the drugs that are coming into the country and being distributed illegally, and both are a tremendous problem in the state, I assume, Chris.
Absolutely. And what will sometimes begin as a prescription drug issue, somebody will, again, have an injury, get hooked on prescription drugs, it turns to street drugs.
Okay.
So that's where you start seeing, again, that's why this partnership between the state and federal agencies is critical.
Okay. I want to give you all a figure, and then I'm going to go back and ask each of you some more detailed questions. I was doing some research, and you'll all be familiar with these figures. The latest figures I've seen, and there may be more recent ones, but they're the best I could find. In Georgia, from June of 2016 to May of 2017, the total number of opioid doses prescribed to Georgia patients surpassed 541 million. That's 54 doses for every individual in the state of Georgia. Does that ring true?
Yes, it certainly does, and it's just as alarming for me as a physician as it is for you.
So, with that in mind, maybe in terms of the prescription misuse of opioids, that sort of helps us answer a key question for you, which is, why are we seeing this spike in opioid abuse? Is it spiking, or have we just not paid attention to the problem before?
I think it is spiking to a degree, but I also think that the spiking has probably been occurring for longer than we have really been paying attention. I think back to the years when I was a practicing emergency physician, and we had a pain scale on the wall so that we would ask patients when they came in, is your pain a 1 or is it a 10? And we were encouraged to be sure that the patient's pain was totally relieved. I think we went overboard. And I think that that's part of why the spiking has occurred, particularly over the last 10 years.
Anybody else want to weigh in on that? Because I think that's really important. In terms of legal, you're a pharmacist.
Well, I attended a meeting with my agency and the medical board probably 15 years ago, and just to go along with what Dr. O'Neill said, that meeting talked about the lower reimbursements for hospitals and doctors when patients got out of the hospital and were in pain. They wanted to aggressively treat that pain, and they wanted to be the medical board to be okay with it.
Yeah.
And that, I'm with you, that started a rise, I believe, as well as a pharmacist. Certainly that started a rise up a hill that is we're at the top of, or I hope we're at the top.
Well, yeah, and from my observation too, coming in and seeing this is the challenge that we have is opioids are legal. I mean, there is a medical use for opioids. End of life, cancer treatment. Had a friend in the burn unit at Grady. So the challenge is, yes, there is a purpose behind that. In fact, I had a friend whose mom called when she heard me on the news talking about going after the opioid crisis, saying, well, wait a minute, what's going to happen to my opioid, my prescription? But the problem is then the challenge is those that are abusing the system. So how do we confront that? And I want to commend, there are some of the pharmacies that are Walmart and CVS that are now limiting the number of days of prescriptions they'll give, up to 7 days. Some of the insurance companies doing the same. We're now, through the medical board, doing more training, through the pharmacy board, doing more training to address these issues. And that's what you got to be able to get this all-in issue addressed with.
So if you're working FBI or DEA in Georgia, you're in territory where the problem in terms of opioid overdose deaths is significant. Georgia's among the top 11 states with the most opioid overdose deaths, and 55 Georgia counties have an overdose rate higher than the national average. Do those figures ring true?
Well, one thing for the FBI we recognize, and my DA counterpart can say the same thing, is Atlanta is a hub for the East Coast of drugs. So as he was saying that drugs move their way from other countries into the United States, well, they make their way from Mexico to California to Atlanta, and then it's dispersed up and down the East Coast. So some of those drugs stay here. And if they're all coming here, then we're going to see an increase of these overdoses as well.
So let me make sure, and then you can answer that. Are we now talking about illegal drugs? Are we talking about opioids as the gateway to the illegal drugs that you're seeing coming into the country? Is that a correct assumption? Or are you also telling us that there are counterfeit, in many cases, opioids that are coming in across the border and being sold and also responsible for death and injuries? Is that what you see at DEA? Do I have this right?
Somewhat. I believe a lot of the opioid-related deaths are more fentanyl-related.
Which means what?
Well, a lot of these individuals get hooked on regular prescription pills, and then they are unable to get more prescription pills from their doctors. Their doctors refuse to fill their prescriptions, so they go looking elsewhere and they go to the street. And unfortunately, people selling pills on the street are not always selling prescription pills. They're selling counterfeit pills. And these counterfeit pills look exactly like the real thing, except they're not hydrocodone, they're not roxycodones, they're actually fentanyl. So you have people that are used to taking 3, 4, 5, 6 pills a day, sometimes more, sometimes 15, 20 pills a day. And then they get a bottle of fentanyl pills that they believe are roxycodone pills. They start taking the pills, they overdose and die. And that's the trend that we're seeing.
Yeah. What's the effect of fentanyl on the body? To our pharmacist and our doctor of public, our head of public health, what does fentanyl do to you? I mean, it's poison. Yes?
Well, certainly in high doses, even
yeah.
reasonably high doses, it's poisonous. But it basically, it obtuns the brain, it relieves pain, it also will essentially make you go unconscious, and it will stop your breathing.
So are there legal and acceptable uses for fentanyl? I want to make sure our audience understands all this.
Absolutely. Fentanyl was first used primarily by anesthesiologists in putting folks to sleep for surgery.
Okay. So it's the illegal fentanyl that comes in that is not within the safe limits that leads to the problem. Is that right?
We see it both. We do see people getting fentanyl patches and illegally misusing fentanyl patches. However, the majority of the overdoses that I have seen, I'm speaking for me personally, not statewide statistics, are usually fraudulent prescription pills. So it is powdered fentanyl that is coming into the United States and is being pressed into pills, and those pills are being distributed out into the community. We also have a problem with analogs of fentanyl, carfentanil, acetylfentanyl, that really have no medicinal purpose whatsoever. It's the same thing. They're coming in powder form. People are taking these drugs thinking they're taking something else, and they're overdosing and dying.
Do you want to
that's what I was going to say, too, is the carfentanil and the other analogs. where they're 10,000 times more potent than heroin, and it's an elephant tranquilizer. And this is an issue for first responders. You get one flake of that on your skin and you can overdose. So again, that goes back to protecting those that are out trying to protect our communities.
So let's go back to legally prescribed opioids for a moment. I'm beginning to see more and more attention given and perhaps more pressure, public pressure being put on physicians, dentists as well, to be more conservative in prescribing opioids to their patients. And I'm wondering if you think, among the other solutions to the problem, that pressure will only get more intense as the problem becomes even better known, and that might be part of what you have to do to solve the problem, is physicians don't want to be seen as drug pushers, essentially.
I think you're completely on target, Bill. I will tell you, though, that I do have some concerns, and I voiced this concern to Attorney General Carr and to others. I think that we will undoubtedly do a good job in Georgia of curbing the prescribing of opioids. That's not to say we're going to stop the prescribing. By no means do we want to do that, but I think we will curb it. What I don't want to have happen, though, is what has happened in some other states where as physicians have become much more circumspect and more careful in the way they prescribe these drugs, folks are turning to the illicit trade. And in fact, in one state, we saw the death rate from heroin be 4 times as great as the death rate from legal opioids.
I'm glad you pointed that out. So you're nodding, Mark. I mean, that's the beginning of an understanding of how complex this problem really is. And that's only the beginning of understanding the complexity, right?
Yes. What he was just talking about, especially with the legal drugs, it does do a slippery slope into the illegal side, where with these new laws and new control measures that we're trying to go with the pharmacies and the doctors, it's getting harder for people to buy the pills, the legal pills, which is going to be more expensive on the street. So because of that, a lot of people that are addicted to the pills are going towards heroin because it's cheaper. They can get a dime bag, which is about $10 to get a shot. The danger about that is what we said before, is a lot of the heroin is being mixed with fentanyl. And the people that are shooting this are thinking they're shooting straight heroin, and they're actually got fentanyl, and they're overdosing on it.
All right, I have a dumb question, which I'm entitled. I have lots of dumb questions. You probably already guessed that. But why does a drug dealer mix heroin with fentanyl? I mean, you're selling less heroin, I assume, but why fentanyl?
Well, the drug pushers, it's a business to them.
Sure.
Fentanyl is a lot cheaper
Okay.
than heroin,
Okay.
and it has the same effects. So they can get a kilogram of fentanyl for a tenth of what a kilogram of heroin would cost, sell it for the exact same, call it heroin. They can dilute it a little more in hopes that they don't kill off their entire customer base, and they just keep selling it. And the downside is when drug users find out that a certain dealer has really good dope, that's the dealer that they're going to go to. And sometimes it's going to be stronger because it's pure fentanyl.
Do you want to weigh in?
Well, just like you just said, also,
Hold that close so we make sure.
just like you just said, it's a business. So if you have a kilo of heroin and it sells for $60,000, if I'm a drug dealer, I can cut that with fentanyl, and I can have 2 kilos of heroin and sell it for $120,000.
I see. It's not like, when I see the movies, the TV shows, it's usually like some kind of powder that's, doesn't have any impact at all except to cut it. But you're saying this will get you high. You don't need as much heroin to sell to get them high, is what you're telling me, right?
Exactly.
Okay. What about the problem of pharmacies that are doing out the back door selling opioids to patients?
Well, we saw the huge increase of this came when Florida ran them out of Florida with the pill mills and the physicians and pharmacies dispensing there. And it all went back to the money, as these gentlemen, I'm sure, can tell you better than I. It always goes back to the dollar and how much they can make. They, just like in their business, and I see it from the pharmacy side, those doctors, just like the pushers and just like the dealers, the doctors create the addicts with the oxycodone and the hydrocodone, and they create those addicts, and they keep them coming back. You've never seen patients so compliant to go to a doctor every 28 days as they do when they know they're going to get 120 oxycodone 30 milligrams, 90 Xanax, and some soma thrown in there. They are great patients that I'm sure doctors wish they could get blood pressure patients to do, but it's that same cycle just with a legal white coat on. We create addicts, we have them then come back to us, and you've got those pharmacies just like doctors who decide, I can do this under the radar and I can make quite a bit of money if I just go ahead and do this.
Okay, so let me, if I may, go back to this notion of controlling the prescription of opioid, trying to get doctors to cut back. I suggested that one way maybe that could happen is if doctors start getting so much pressure from the public, they don't like the image that they have anymore. But what about legislation? What about state law, Chris Carr?
Well, and we've focused on that. The prescription drug monitoring program is one of the things that we focused on, where both docs and pharmacists are going to have to start using. I think, and that will give some data both to the doctors, to the pharmacists. We're going to know how much a patient is asking for, how many different docs they're going to, how many different pharmacies. Hopefully that's going to cut that down. So I think what we have done, I think that information is going to be powerful to us. And that's something that the legislature has worked on with docs and pharmacies, and I think deserve a lot of credit.
And I think this last legislative session was a perfect example of just how effective that could be. In the past, we were not able to share information out of the PDMP, the Prescription Drug Monitoring Program, with other states, other than the original 4 states that we agreed to in the beginning. But there was legislation introduced and it passed such that now we can share with all states, which, the drugs cross borders all the time, so it makes good sense for us to be able to share that information.
Okay. Let me stay with you for just another second. The only experience that I've had with opioid prescriptions are with a dentist, where I routinely, not often, but when I have some sort of oral surgery, I get oxycodone. I'll bet that's true for many of you in the audience here. Okay. I've never taken one because it seems to me unnecessary. I take a couple of few Advil and a couple of Tylenol and get pretty good relief. So, I mean, that to me, the question is, does the dentist have to be prescribing an opioid? And this is not, we're talking in broad general terms. I'm not certainly trying to indict any, and I don't mean that in your terms, anybody who prescribes them, but are there questions about whether they always need to be prescribed? Your burn unit friend needed it. Is that a fair question?
I think it's a great question, and I'll turn to my pharmacy friends here and let them jump in on this too, because as a physician, I think I've come to understand that in many situations, non-opioids do a better job of relieving pain than opioids for certain situations. And it's not just dentists. Across the board, practitioners that have DEA numbers are able to prescribe, and very often prescribe unnecessarily. And it's not just dentists. I will tell you, though, that most recently with the PDMP, the one group that we've been struggling to get to register for the PDMP, because they have the DEA numbers just like physicians do, are the dentists. And I'm really pleased the dental board has taken some very strong action lately. They are going to start fining dentists who have not yet registered. The requirement was that all practitioners that have DEA numbers and are licensed in Georgia register by January 1 of this year. Right now, we are 90% compliant across the state, but we still have a need for more dentists to register, and the dental board is taking strong action.
Is that your experience as a pharmacist?
Yes, well, and I think it's a huge plus what Attorney General Carr did, because it's that communication. That PDMP is a tool, and it started out as a tool that's growing into something that's becoming more of a tool for enforcement and other things, but the key was getting people to look at it. It was, the first year there were 5,000 physicians registered out of, forgive me, I don't know how many physicians there, but there are a lot more than that, and pharmacists. The key was getting the word out and getting them to look at it, because if a person walks in and you're a pharmacist behind the counter, like I said, I own my own pharmacy, you're going to make a professional decision based on that piece of paper they brought in, right, or that phone call, and then your interaction with your patient. boy, to pull up that PDMP and to use it, to take the time to look, that's a whole world of information you just gathered that you didn't have, that took a minute and a half. So the communication that the task force, and as the feds, forgive me, that's a nice term. We just call them the feds. It's an endearing term.
We've been called worse.
Yeah. Is critical for all of us because we work with DEA all the time in these things, and just that communication to use this tool that's out there. I mean, we're going the right direction, I believe, truly, in how we're. It's just a lot of things that have to happen to help these people that are addicted to these things.
Okay, so let's go back to the hardcore law enforcement side of this. You two feds, you described the fact that you are working together much more collaboratively than perhaps in bygone days. How does the state? How do you all interact with Chris Carr's office, with GBI or whatever? How do the state and the federal agencies work on law enforcement together?
Well, example, for my strike force that I'm on, we have local and state what we call task force officers on our squad. So they support us just as much as we support them. On the federal side, we will deputize them to allow them to have federal jurisdiction to help us with our investigations. And we kind of feed on each other. Georgia's a big state. We have to depend on the local law enforcement. People got to understand, local law enforcement are the first people out there to deal with this. We're not always on the streets. We're not the first ones to deal with it. So we have to depend on the state and locals to assist us and bring that certain crimes or certain targets to us, but also we commingle and co-work together to one goal. We got to put these people in jail.
DEA, you're part of that same equation, right?
Yes, just from our standpoint, we handle the regulatory side as well, which I don't have a lot of experience in, but DEA has tactical diversion squads, which are comprised of investigators that handle the compliance and regulatory side of the house, dealing with doctors, their abilities to prescribe medications, DEA numbers. We pair them with agents and local task force officers that work hand in hand with these diversion investigators to conduct criminal investigations into doctors, into pain management clinics, into pill mills that are illegally prescribing way more opioids than they should be. All
right, Chris, help me understand in terms of jurisdictions. So the city of, you get a call from, do you get a call when a local jurisdiction says, hey, we're monitoring illegal activity going on, whether it's, well, let's talk about illegal drugs. Your office itself doesn't get involved until there's going to be a prosecution, or am I wrong about that?
Well, no, most of the prosecutions would be done at the local level through a DA,
okay,
sheriffs, or at the federal level through the U.S. attorney. We've got a piece of Medicaid fraud, and so we talked about that before, if somebody's defrauding the system. But that's why that collaboration and communication is so critically important. But most of the prosecutions would be done through local DAs.
Okay. So as the head of the statewide opioid task force, what are your goals? Are your measurables? I mean, I assume you have short-term and long-term goals. What right now are the things that matter most?
Well, a couple of things, and we brought this up. One of the things that I saw is obviously we have some great task forces that we're dealing with at the law enforcement level. We've got passionate folks that are involved in this issue. We've got nonprofits. We've got agencies that are working on this issue. But one of the things that we saw is we weren't communicating. Law enforcement, I think, does a great job communicating within law enforcement, but knowing what the nonprofit is doing and have the nonprofit know what law enforcement's doing, knowing what the state agency is doing. So we've created this task force a little bit differently, Bill. It's not 6 or 7 people going around the state to take testimony to come up with a white paper. It's actually building an infrastructure of communication amongst all the different groups that are involved in this. Open to all 10.4 million Georgians. Anybody who has an issue, and we're asking 3 questions. What are we all doing to address this crisis? 2, how can we leverage those experiences, those assets, those resources that we have? And then 3, if there's a gap, how do we fill that gap?
Okay, so what's an example of the kind of information you would share with your federal partners?
We would bring the experts to the table, and we've done this a couple different.
What kind of expert?
So we the first meeting we had 35 different folks. We had DPH, we had DEA, we had Dennis was there, and we said give 2 or 3 minutes. What are y'all doing on this issue? And then after the meeting, we said, stick around. If you heard something that your group's doing, instead of reinventing the wheel, let's come up and let's partner together. In fact, we started DPH, Public Health, Community Health, and Behavioral Health are now taking the lead on creating a statewide plan. As a result of that, we've created now a website called Dose of Reality because we realized there wasn't that one source of information, communication that folks could go to get information about the opioid crisis. So we've done Dose of Reality Georgia. So those are the kinds of things that are kind of coming out of the task force.
All right. Can you talk to us at all? I mean, I recognize that you didn't come here tonight with an armload of data. So I guess I can ask this in the most general way possible. Are we seeing a lot of federal prosecutions for drug abuse, either whether it's illegal drugs coming into the country, whether it's illegal sale of opioids or fentanyl, whatever? Are we seeing a lot in Georgia these days? And have arrests and prosecutions picked up from the federal point of view?
The exact number, you're right. I don't know.
Yeah.
I can say that we are working fentanyl overdose cases. We're working fentanyl distribution cases with our partners in the U.S. Attorney's Office. We liaison a lot with state and local agencies, along with state and local prosecutors, to try to, get a grasp on what's actually going on.
Okay.
Yeah, I mean, we're strongly taking an active role in trying to prosecute these cases. The United States Attorney's Office has been great. They've helped us out. They're willing to take these cases, especially the opium-related cases. So we're definitely seeing an increase in the amount of people that we are indicting and hopefully convicting.
Let me go back to state public health. How are you working right now? Let's say I develop an addiction to opioids. What do I do if I really don't want to be there? I'm determined to kick this habit. Where do I turn in the state of Georgia to get help? And what will you do with me to help me get off of this drug?
Well, first of all, let me say that we in public health will not be actually the entity that will be treating you.
Right, sure.
What we would be doing, however, would be trying to give you the information that you would need to know where you go to get that particular help. And there are really two different areas that you're going to go into. Either you're going to be on the private side, where you would be going to an addictionologist, a psychiatrist who's had specialty training in addiction disease, who would essentially be helping you come off of whatever the drug was. Or you can go through our state agency, our sister agency, DBHDD, Behavioral Health and Developmental Disabilities. They have a series of clinics all over the state. And predominantly the modality that seems to be having the most success is what we call MAT, medically assisted treatment. That's using drugs that will keep an individual who is addicted from going into withdrawal, but does not give them a high. So it doesn't cause them to want more and more of that drug, but it will keep them from going into withdrawal so that they won't turn back to the original drug that they were addicted to.
And you've had success with treating it this way.
Yes. I haven't, but my colleagues have.
Right, I understand that. This is really tough to beat this addiction. Yes.
It's extraordinarily tough. And I think, I had a question in Augusta last Friday. We were doing a talk in Augusta about this. And a person said, well, we saw this individual in our community who overdosed 3 times in a row. They were salvaged with naloxone 3 times in a row and then went right back to the same thing all over again. And the question to me was, well, doctor, what should be done about that? What do we do if we're going to give naloxone? We just going to let them keep on doing the same old thing over and over again?
Yeah.
And I think the answer is we've got to have, as part of our treatment plan, as soon as we have an overdose, we have to have a soft handoff to the treatment side right away. We can't wait a day or 2 or 3 because they are going to have more problems. They're going to turn back to the drug again. So there are several programs underway right now so that when an individual is taken into an emergency department, as soon as they are basically stable medically, They are then immediately started into a treatment program right there in the emergency department, getting their first dose of the drug that is going to allow them not to withdraw, but not to get a high.
You told me before we started you have a son who is a firefighter and an EMT. When he responds to a drug overdose, what are his steps to try to, first of all, keep this from getting the condition from escalating into possible fatal situation, and then what does he do with that patient? Put your microphone up so everybody can hear you.
The county he works for, of course, he's following there, and they do extensive training on that, and to be careful, like Chris said, the amounts of this fentanyl and those types of fentanyl can be very dangerous. These paramedic firefighters, and sadly enough, though, that's not the first thing that's on their mind just in talking to him, because, of course, as dad, I'm saying, son, be careful while you're... Yeah. But their first reaction is, I'm sure like us in our jobs, it's going to be help these people, though. And so that's the scary part to me for those first responders, is that they want to help that person stay alive. And so with the naloxone, and boy, the availability of that has been tremendous. But I think that's just a huge risk, because they go in there to save a life, and that's what they train for every day, and that's how they...
Yeah, but that was so controversial for so long, whether we should give emergency responders, police departments, whatever, something that would be would immediately stop the dangerous impact. Why was it so controversial, and why did we finally overcome that?
Well, fortunately we did.
Yeah.
And fortunately we did, and I commend all those that have been working on this for so long, because it does make a difference, and we continue to hear stories about it.
Okay, all right, let's move on. So here we are today, tonight we're doing this program. We hope that there are people across the state who are watching this on our web, and this program will be available to view as a tape program later. So that's great. But what else? How is the state doing? What is the state doing to really address public education on this whole issue?
Well, I think two things. One is the statewide plan that we're working on right now. That, as I mentioned before, public health, community health, behavioral health has taken the lead on, and 5 different areas that we're going to be focusing on that. But secondly, again, we have this website, Dose of Reality, because, Bill, what we had heard, there is no one place to go get information. Our website's broken down for students, for parents, for coaches, the medical community. We're going to add a veterans piece, and it really does delve into what can I do. Everything from information about the crisis to how can I help in my community. That's just one area in particular. But the other thing is, again, continuing to call this statewide task force together and focusing on issues. The last meeting that we had, we focused on babies with withdrawal symptoms. Secondly, we focused on more children going into the foster care system with 1 or 2 addicted parents, and oftentimes it's due to an opioid. And then 3, what happens to young athletes? Either I got hurt and that was my gateway, or I got hurt and I got a bunch of extra pills and I gave some to my teammate. Issues that we can address, continue to bring those issues to the forefront and talk about them, because there is a stigma that was related to this crisis. People don't want to admit that their family member is addicted to prescription drugs. And it's like with alcohol or other addiction. We have got to get over that stigma, and the only way you do it is talk about it so that everybody else sees I'm just like you.
You talked, I loved the fact that your first remarks, Mark, you talked about all that FBI does beyond the law enforcement aspects, but go into it a little bit more. I mean, I learned a long time ago in working with FBI when I was running a nonprofit for a while in the city, how deeply involved you are with the community beyond catching bad guys. So talk a little bit more about the aspect of your agency that is dedicated to helping educate the public on this crisis.
Okay, well, reference that, we'll talk about the healthcare fraud squad. Talking with the supervisor, special agent there, David West, who's out there in the audience. One thing they like to do is they're going to go out and educate the young pharmacists that are in school right now. They're going to tell those pharmacists and educate them on what they need to be looking at when it's coming to these fraudulent pill mills, these fake prescriptions, but also let them know that now, they could be held liable. They could be, possibly prosecuted, if they're in the wrong. But just educate them what they need to be looking for, what their responsibilities are. And the same thing for the young doctors coming out as well. They'll talk about, fraudulent billing, what their responsibilities are, what should they be reporting, what should they need to look at, who they need to report to. Because sometimes when they graduate, they're new. They don't know all that stuff. And the FBI will go out there and help educate them and allow them to know, what are some risk factors and who do I need to talk to about that.
Okay, thank you. How far behind the curve are we on this? I know, you've got a task force, you're working hard, you're looking for solutions. You guys are doing it at FBI, DEA, you're out there enforcing the law. But how far behind the curve are we really?
Well, the whole reason we've got behind this, Bill, is because if there is one more funeral and one more death, then we're behind the curve.
But there will be. And the question becomes, is it continuing to spike upward?
Well, when you say
this is not your personal situation. It's not like you can change it. So I'm not asking you as AG of the state whether you've solved the problem. All of you combined, are you making genuine progress, or is it still out of control?
I think we're making progress, but we've got a ways to go. When you see, again, Walmarts and CVS's and those types of entities, the prescription or the pharmacies reducing the number of prescriptions. When you start seeing insurance company reducing the number, when you start seeing doctors now changing the ways that they are training, when you start seeing more conversation about it, then yes, I think we are making progress, but I think we got a ways to go. Now, the state of Georgia has been recognized as one of the top 13 states in the nation to do something about the crisis. So hopefully we'll see prescriptions come down. Hopefully we'll see the number of doses come down, and that's progress. But again, if there's one more funeral and one more death, we got a ways to go.
Let me stick with the opioids legally prescribed. What's your sense of whether you're making genuine progress or the curve is still upward?
I think we are beginning to make genuine progress, but very slowly. I think it's going to be probably, I'm guessing, another couple of years before we see the degree of curtailment of prescribing of the legal opioids that I'd like to see. But one other thing that I would add to what Attorney General Carr just said that I think is going to be absolutely critical to our success, and that is that we have got to be thinking so far beyond the opioid crisis and be thinking addictive disease crisis. And we've got to be thinking, how do we prevent addictive disease? It's not just the opioids. It's that entire spectrum. And it starts with kids in school. In grade school. That's where we need to start the education. We also need to understand better what is it that is a proclivity toward an individual becoming an addict, and what can be done to interfere with that as an interrupter to keep that from happening. We don't have all those answers yet. A lot more research has to be done in order for us to really address this in the most effective way.
That's really an important answer. Thank you for adding that to the conversation. From the pharmacist's point of view, making progress in terms of them being more aware of how they prescribe these drugs?
I do. I think after the pill mill, I think that really peaked back in 2010, around that time period. A lot of education done with pharmacists and a lot of action taken by the pharmacy board on pharmacies. And so I do believe they are being more educated. I think they're more aware that I can't just because it's on a paper from a doctor, I can't fill the bottle up and dispense it anymore. So I think that's the corresponding liability that pharmacists now in our law, and that was probably 10 years ago, got changed. Now the same corresponding liability as a physician have if you're prescribing it for non-legitimate reason. Well, now if you're dispensing it for non-legitimate reason, you can be held accountable. And I got to throw kudos to the DEA and their tactical diversion squad, who about 10 years ago came in, and we've worked with them for years on doctors, pharmacies, and their attorneys learned the process. And it's hard to, he can tell much better, it's hard to prosecute a doctor and a pharmacy when they have that license on the wall. And I think with their help, I do think we have made a progress, but we got a long way to go.
So I left the federal agencies for last on this because as dedicated as you are, sometimes I can't imagine what it's like to wake up some days and realize that you're making arrests, you're identifying dealers, you're trying to disrupt supply chain, but the illegal drug distribution in this country seems to be an endless problem. Am I being way too pessimistic? DEA?
I'll take the shot first. I think that it is a problem, but one thing that I learned, I was a local police officer here in Cobb County, Georgia for about 8.5 years before I joined DEA. So my community outreach was very limited then. When I joined DEA, we have a couple of programs that I'm actually quite proud of. Red Ribbon Week is something that's very important to DEA. It celebrates the life of an agent that was murdered in the line of duty in Mexico back in the 1980s. And a week every October, DEA goes out and talks to schools. We talk to grade schools. We talk to middle schools. We talk to high schoolers. I've had the opportunity to talk at several schools. It's a fantastic experience to go out, get the message out to these young kids that there is a problem out there and they need to be aware of it. The second thing is the national take-back that we do, the prescription drug returns. We partner with state and local and other federal agencies across the country to have take-back centers where people can bring in unused prescription medications and dump them into receptacles, no questions asked. And I don't have the exact figures, but it's hundreds of tons of drugs that we collect every single one of these take-backs. And the first one that I did up in Washington, D.C., I was amazed at how many pharmaceuticals people just keep in their house, just unused, sitting on a shelf somewhere. And this program allows them to bring them to a safe center where they get disposed of in a safe way. They're not flushed down the toilet, which we don't recommend. Don't flush them down the toilet. Take them in one of the take-back centers, let them be disposed of properly. It gets them off the street, and we don't have to worry about somebody's kid getting into the medicine.
Proactive, doing what you can despite the massive problem you face. You know, Special Agent Heisman, like a lot of people, well, I watch Narcos on Netflix. I don't even know how you begin to address the flow of illegal drugs into this country.
Well, between FBI, DEA, ATF, Homeland Security, I think we're doing a great job. But what people need to understand, it's just not the feds. It's state and local. Everybody's doing their part in battling the drugs. Now, everybody says, like you said, it seems like there's an endless amount of drugs coming in. Well, I don't look at it that way because I have to investigate this and I put countless hours in. And I'm pretty sure I'm speaking for local, state, and federals. Hey, if I can get a kilo of dope off the streets, that's a kilo of dope that's not going to go to a child or somebody else and prevent a death. So I do think we're making a dent.
It's what you said. One more death is unacceptable. He's saying the same thing a somewhat different way.
That's exactly right. That's exactly right.
So we have time for a few audience questions. If you'd like to ask a question, raise your hand and we'll bring a microphone to you. Who has a question on a subject that perhaps I haven't touched on? Anybody want to ask a question right now? Yes, sir. Could you stand up when you ask your question so everybody can see you?
Hi, my name is Alex Gutierrez, and I thank you all for coming here tonight. It's really educational. My question was in reference to cannabis oil. Do you think that may play a role as far as perhaps eliminating the opioids, as far as pain medication for patients who need?
See, I knew this audience would be smarter than I am. That is such a good question. Chris Carr?
So that's an issue that the Georgia legislature has been dealing with. And it has been last couple of sessions, a couple of different bills have passed. The challenge that you have is there's also a federal legal system that comes into conflict with it. And I know that there have been conversations over the value of medicinal marijuana, and there are concerns over recreational use of marijuana. And so I think that conversation is going to continue in the legislature going forward.
Yeah, it's interesting. Well, go ahead, Doctor.
I think the other thing that we have to ask is, are there not circumstances where it may also be the gateway?
Anybody else want to take a crack at that? What's the pharmacist's reaction to that question? See, here's the thing. Everybody's being really cautious. Did you happen to notice that?
Well, interesting. The question is coming more and more, and an interesting question right now that is being actually going to be debated with the pharmacy board as well as Attorney General Carr's office has been involved. Is You drive around and you see CBD oil for sale in pharmacies, but in gas stations and around the
Really?
state. Yes, sir.
Have you all seen that? I've never seen that. Oh, okay. I've got a bunch of people nodding. Now, on the federal side, you can't be in this world, I don't think, because you're responding to a Justice Department. Well, you're responding to the fact that any form of marijuana is a Class A drug, right? So it's irrelevant as to whether you think medical marijuana may relieve the problem, or is it? Nobody wants to answer this question.
Neither one of us.
All right. Who else wants to ask a question?
Hi, my name is Allie. You talked a lot about prosecution and a lot about education, but how are you educating judges and prosecutors to refer to treatment rather than just incarcerate? Incarceration is not working either.
Well, I'd be happy to take that one because the criminal justice reform in Georgia, where we've truly been a leader, and that's where accountability courts matter. And I think we've truly been a leader on that front, and Justice Mike Boggs has really spearheaded that for the governor. And when you see an accountability court, a drug court, a family treatment court graduation where families are reunited, it's one of the most affecting things you could ever see. But what it does is it really takes folks and say, look, you've got to have a complete change in lifestyle. It's a commitment. It's not a 1 week commitment. It's not a 1 month commitment. In fact, Justice Boggs will tell you it takes 8 months before you're going to see whether or not that individual is going to change. So that's number one. Number two, and Commissioner O'Neill talked about this too, rehabilitation. That is a challenge in non-urban Georgia. What you end up seeing is you see law enforcement ends up being the treatment facility. And you'll hear sheriffs in rural parts of the state that will tell you we are arresting the same people over and over and over again because we don't have alternatives. So that's something that's a challenge as well.
You know, that raises a good point. Why is it that in so many states there's a focus on rural addiction? I mean, obviously there's a lot of addiction in urban communities too, but what is it? But why the rural parts of a state like Georgia do we see such a focus on that?
I don't really know the answer to that, Bill.
But it's true. Am I right?
I think you're right.
Okay.
And I think that it has to do probably to some degree with the fact that the stigma in rural communities is different from the stigma in urban communities. And because of the stigma being so strong in a rural area, there's a much greater tendency, I think, for a lot of this to be hidden and sort of pushed under the rug.
Okay, that's interesting. Who else? Somebody else. Yes, sir.
My name's Tony Hope, and I just thank you for coming out, and it's been very educational. But do pharmacists hold the right to deny customers' requests to refill their prescription even if they have the doctor's note?
Another great question. What's the answer, pharmacist?
In the state of Georgia, a pharmacist does not have to fill a prescription. So they do. In their professional judgment, they can refuse to fill any prescription. So that's not a violation of a rule of the Board of Pharmacy. That's not a violation of law. That's where the state is depending on the pharmacist to make a professional judgment, because it's, in fact, they can, if they fill something too soon, we're talking about opioids. Somebody has a pain pill and they're supposed to last 30 days and they're coming in for 20 days to get it refilled. That pharmacist should say no because something's weird, right? Those pills are going somewhere they shouldn't be going, or they're being taken too often. So you hope it's being practiced in the right way, but the fact is a pharmacist in Georgia does not have to ever fill or refill a prescription.
So that's interesting, too, to me. We already know there's such a thing as doctor shopping. You know, I go to a doctor to convince him I need hydrocodone for whatever reason. He says no. I find the doctor who says yes. But I assume there's pharmacy shopping too, you know?
And Dennis and I were talking about this earlier. That's where electronic prescriptions may end up playing a big role. And that may be something that really, again, talking about moving forward, that's another issue that can help us.
Okay.
And Bill, also that's another area where the PDMP comes into play, because not only does it help us understand when a particular patient is going from one doctor to another, but we can see when they go from one pharmacy to another in the PDMP.
Okay. Katie is monitoring questions on our website. What do you got there for us, Katie?
Well, Nick would like to know, he would like for you to dive a little bit deeper in what ways are opioids presented on the streets in suburban areas?
We're seeing it in both powder form and pill form. A lot of the times the pills that we do see look exactly like real pills. They're just not real. So they're either carfentanil, acetylfentanyl, some other analog of fentanyl, or fentanyl itself. That's how the majority of the time it's presenting itself in suburban areas.
So the pills I get, how is the powder then used?
Both the powders and pills can be used the same way. Generally, it can be crushed, snorted.
Okay.
It can be crushed and cooked and injected, or the pill can just be taken, or it can be, a myriad of other ways.
We got another question up here in the front, I think. Why don't you stand up and we'll get a microphone to you, sir. Here we come.
Hey, Dominic Stokes. Just got a quick question. When you talked about the overdose, what's like the age range for a lot of the cases of people that are overdosing for the opioids?
The ones that we're seeing out on the street are young. I mean, mid-20s to early 30s, up into 40. But we are seeing a lot of post-high school kids that are overdosing. So a lot of younger people.
That's heartbreaking.
It is. But the CDC has put out data from 2013 and 2014 that nearly half of all overdoses then were actually in the 45 to 64-year-old range. And why is that? Knee replacement, back surgery, whatever it may be. So you're seeing it on both ends. There's no doubt what our federal partners are seeing. And I think on the other end of the spectrum, it's the prescription drug side of things versus street drugs.
Hold that microphone right up to your mouth so we can understand you or hear you.
You mentioned earlier about the website where you can get more information about the crisis. What can be done to really target like a lot of the middle school and high schools going forward? Do you foresee more panels like this really educating the community about this crisis?
I think it's all in. Panels, conversations, partners getting the word out. And one of the things, and Dr. O'Neill and others were talking about educating young people. Kennesaw State's got a great recovery center on campus, and I was up there recently, and I got a chance to meet with about 10 to 15 students. Ask any of them when they got involved in drugs or alcohol, 11 to 13. So you're talking about focusing on elementary and middle school? Absolutely. But hopefully this website will help with that. And also, as the DEA mentioned, they've got a great take-back program on our website because we want to focus on those days, but we also want to make it part of what people do throughout the year. We've got an interactive map where you can put in your zip code and you can find out where these take-back boxes are.
We're going to, if you're watching the program on the web, we're going to have all the web addresses for the agencies and the places online that you can go to look at some of the help that's available out there. Katie, you have one more web question for us?
Yes. My last question would be, what are the DEA and the FBI doing specifically to address this? Again, another suburban-based question.
Well, you're doing the same thing in the suburban areas that you are everywhere else, I assume, but this raises the question of, it is certainly true, is it not, that suburban drug use has just spiked enormously because of the opioid crisis and beyond, right?
For sure, unfortunately, the opium crisis, it's a designer drug now for the younger kids. But we as the FBI, and I'm pretty sure DA say the same thing, our investigations are not geographical. Wherever these investigations lead us, we're going to go there. So whether it's in a predominantly low-income area or a high-income area, we're going to do that investigation, and we're going to do it the best we can.
All right. Thank you all. We are just about out of time for this program tonight. And I don't know about you, but I feel like we have heard some staggering information about this crisis. I think everyone who's watching will agree that we have a long, long road ahead in addressing and combating the crisis caused by opioid abuse, although truly these gentlemen on the panel tonight are working as hard as they can to solve this crisis. I thank you all so much for your participation in this panel tonight. I learned a lot. I think our viewers probably did as well. And if I can say it, thank you for your service. We really appreciate your efforts in this terrible crisis we're dealing with. Thank you so much. So, yeah, go ahead, applause. as I promised, we've got some resources for you. For if you have crisis, if you need crisis support, use this number, 800-715-4225. For non-crisis support, call 844-326-5400, or you can call 800-662-HELP. There are also a variety of web resources available, as I mentioned a minute ago. They're available on the GPB website. We want to thank the following sponsors for this program: FBI Atlanta Field Office, the FBI Atlanta Citizens Academy Alumni Association. Thank you so much to you, and thank all of you for watching. Again, for more information and resources, go to gpb.org/townhall. Good night, everybody.